It's a trauma. Yeah, that would be a tricky one. We may not get to that, but this is my talk. It's a bit of a muddle, but a bit on tibial nailing, a bit on plateaus, a bit on removing hardware. That's something no one ever tells you about. So, if we get on a periprosthetic and a tricky femur, then that's great. Tibial nail. So, look on the left-hand side. And that's the fracture. That goes up at the morning meeting, okay? It goes up at the morning meeting. It's distal tibial fracture, uncomplicated, doesn't have a CT, that's just what you've got. And the boss says, okay, we're going to nail that. And you go, okay, fine, we're going to nail that. And then you crack on, and one of your colleagues cracks on, and you walk into theatre, because you're a bit late because you're doing a U-kite or something. You come in late to the trauma list. The junior guy, or one of your colleagues, has nailed it. It's like that. There are no bosses around. He's locked it up. It's locked up, and he's like, oh, I don't know whether to do. He's I just backslapped it, and it's like that. What am I going to do now? Over to you. I'll give you a version of what it should look like, just to help you. So what are you going to do?
Yeah.
So obviously this is unacceptable because the ankle joint is completely misaligned. There's a lot of angulation there in the distal fragment. So I think this needs to be redone. And if the patient doesn't sleep, I think I would redo it on table. So I would take the locking screws out, take the nail out, put some blocking wires or blocking the screws in order to try and get the blocking the screws.
Can I toss this over to you? You good at catching?
This is mine.
This is mine.
Top button. Top button. Show us where your blocking screws going to go.
If you this fracture, you have to be able to catch.
So I would put my blocking. I would take the nail out and put my blocking screw out here on that side.
Yep.
And then the nail should end up in a slightly straight. Sorry, I'm just pointing at
right.
other people. The nail should end up in that plane by putting a blocking screw out there.
Okay. Who's worked recently at the Royal London? Someone other than you, Yang? What do I normally bore on about at the morning meetings? In relation to tibial nails.
Entry point.
Medial on the tibial platform as possible.
As medial as possible. So we're going to move this over here.
Yeah.
Is that correct? The deformity for us?
So lateral.
Right, so we move them lateral. Okay. Who thinks that moving this a bit further lateral is going to cut the mustard here? Okay, so is everyone sitting with Yu Yang's blocking screws? Yeah, go on. Can you throw it? I'm afraid okay. They do go off hand in hand. Okay. The thing. You turned it off. Nice.
Break it as well.
Nice. I like it. So anxious where you turned it
The
off.
left side.
Sorry. Okay. Hello. Okay. The thing I go on about at trauma meetings is this, that valgus is a common deformity. All right? Valgus is a common deformity in the distal tibia because we have a tendency when the nail goes down, the fracture wants to drift into valgus, and so we have a tendency to put the nail down the medial side. That's your classic, oh, I've nailed it, oh dear, oh well, I'm sure it'll be fine. Fractures in valgus, and what is the solution to this? Is it putting a blocking screw up there? Well, here's another one. You can see again, it's in valgus and the nail's down the medial side. If you go to a regular, like this is just a normal tibia that's been fractured in the middle, so it's absolutely anatomic. Same with this one. There's a mid-shaft fracture, nails down, it's totally anatomic, right? Where is the tip of the nail? The nail is not in the middle of the tibia, it's definitely not medial, it's just very slightly lateral to the midpoint of the tibial platform. I'm bored about this meeting, I'm sorry about those who've seen this 1,000 times. Same again, just lateral to the midline. Okay, that's where the nail belongs. It's been done in anatomic studies, this is proven. Okay, so we take you back to here. What's the solution to that fracture? It is to put the tip of your nail, it's to readjust the tip of your nail, right? Because your nail's not in the right place. Put the nail in the right place, and I know it's hard to believe, but just try and reduce the fracture, right? Just reduce it. Just leave the nail where it is, leave it where it is, reduce the fracture. Look what happens to the tip of the nail. With respect to move the bone reduces. Where does the nail end up? It ends up right there. Okay. You could do a blocking screw exactly as you said. This is not the same fracture. You could put a blocking screw there. Let me show you what happens if you put a blocking screw there. Here's your fracture, yeah? There's your fracture. And you've got a nail down, which is sitting, there it is, it's nails down, it's still in valgus. Now look what happens when you put a blocking screw in. It does straighten it up, yeah? But what it does is effectively translates it across. Because the problem was never that this was translated, the problem was it was angulated. If angulation is your problem, which 9 times out of 10 it is, then getting the nail in the right place is the solution. If you're translated, that's different. So in this setting, putting just a nail there, it goes down the lateral side, and actually if you're going to use a blocking screw here, you don't put it there, you put it there. You actually nudge the nail. And I've seen people putting blocking screws in up here. That's not helpful. That's not helpful. All that does is just, again, brings on a translation, actually make things worse. If you're going to put a blocking screw in, it needs to just nudge the nose of the nail inside. Okay? If you're going to do a distal tibia. There is this scenario. I'm just going to whiz through those. Back to this fracture here. Ignore all this lot here. Back to this fracture. Yu Yang, are you sticking with your plan of a blocking screw? After all I've said.
Yes.
Good man! Why?
Because the tip position is not actually awful on that.
Agreed. The tip position is not in a bad place. What's the problem here?
Angulation.
Yes, it's angulation. Would you say that the distal tibia is somewhat translated?
Yeah.
You would, wouldn't you? Yeah? So this is not just an angulation problem, this is a translation problem up here. See how the nail is sitting literally like right over this side, and there's a huge wealth of bone over here in which the nail belongs. So yes, I could move him across a little bit, okay, fine, but that isn't going to solve the problem. What this needs is now reduce the fracture. That's the way to do this. Leave the implant where it is, reduce the fracture, like that, and now there's a bit of bone just poked out here. Bang, that's where your implant goes. So I agree with you, I would take out the blocking screws, I'd get a 3.2 guide wire, and I would put it down on the nail. Doof, like hit the nail. Bang. Yeah? Bonk, bonk, bonk. Back it off a little bit, otherwise it gets snagged on the nail. You hit the nail. Right there. You then knock the nail out. You then, just up to there, not all the way out, just up above the fracture side. You then advance your 3.2 guide wire through the back cortex, boom, and you re-advance the nail. And the nail now has to go round the pin, which is put in exactly the right spot, because it's where the nail wants to be, and it's now gone round, the nail now has to go round your thing, and it all comes straight. Okay? Nice. My tips are, position of the nail tip is crucial, but if there's a translation problem, that's when you use a blocking screw up top. And I'm going to zip past that stuff.
Can I just ask what makes you convert a blocking wire to a screw?
Nothing really.
So you always take the wire out.
I just lock it up securely, and if you've got 2 or 3 lockers, then that's that. Semi-extended nails. Anyone had any problems with semi-extended nails? So Suprapatellar is super trendy now, isn't it? I'm just going to get right to the money on this one. Have anyone had any problems when putting Suprapatellar nails in? Rory, you done many?
Yeah, I've had a problem with, well,
Yeah.
it's more with getting it out.
Getting out, go on.
We had to basically bend the leg up much more than you anticipated to actually get the nail out, but apparently it was a fault with the kit.
I think it's something to do with the Synthes jig. That one of the ones here, you just to get it out at the end, you need to flex them out.
You mean to get the
Get the
jig
jig
off?
out.
Yeah.
Get the jig off. Yeah. Okay. Nice. Any others?
Advancing the reamers. Sometimes you've got to lift the jig.
Nice. The reamers get stuck on the jig, don't they? So what do you do? What's the solution?
Lift
You lift the jig up. That's right. Good. Any others?
PFJ is too tight. Even
Nice.
if you do a snip, it's still really tight.
Yeah. PFJ is tight and you can't get in. Solution?
You can do a snip just trying to increase the space, but even then I have struggled before where it was so hard in the end it actually converted to a patella.
Right. Okay. And a snip is A snip, like when you do a knee replacement, you just take the whole fucking thing off, don't you? That's not a snip, that's like a complete medial release, isn't it? You could do that in a suprapatellar. You could just come down the medial retinaculum, just do a medial retinacular release, just like literally follow it down, do a bit more, until it gives up its secrets, and you're able to get underneath. You can keep going, and then repair it at the end. Right, so medial retinacular release. You can start in the midline and just keep going until the patella floats away.
Suprapatellar arthroscopy will give you the access. Very rare to need to do it, it will give you the access, but it's important because the patella puzzle is the most important thing in the body.
Exactly. So tight PFJ, exactly what you said, Aris. So you need full extension to get the trocar in, so then you need fully extended to get that in, and you can do a medial retinacular release. Struggling with your entry point. So see here how, in order to hit this spot, as you fully extend your knee, the sweet spot for to get the nail into, which is right there, tucks into here. You can't get at it. So you can't put this nail down in a fully extended position. It has to be semi-extended. So 20-30 degrees of flexion is required, otherwise you're not going to be able to do the operation. So if you leave them fully out, or if they're just a tiny bit of flexion, don't underestimate how much flexion you need, I guess that's what I'm saying. It needs 20-30 degrees. Once you've got the trocar down, now bend the knee. Lift the jig anteriorly as well. As you see, take that jig there, lift it up slightly, and what you see is the nose goes down, yeah? Hand goes up, nose goes down, and that sits you on the sweet spot. Then you find your guide, fire your guide wire. Yeah? And also you've got these, most of the systems that have like 2 wire options, so you can shoot one down. If it's not perfect on the AP or the lateral, you can dial it round like a Gatling gun and shoot another one, and that's better, that's now in the right place. Reaming tube keeps backing out, yeah? So this is a absolute nightmare, isn't it? And exactly as David says, every time you pull a reamer out, it tends to get hitched on here, doesn't it? It gets hitched on the thing, and so there's so the jig wants to. If you let it, that jig will pull out. And most of the systems have some way of controlling it. This is the Synthes one, which I have to say is a bit clunky, and I wouldn't have done it myself. The Striker one is much better. They have wires going down into the tibia. But every system has a mechanism for anchoring that tube down once you've got it down, and you must use it. It's really tempting not to bother, oh fuck it, I'll be fine. And before long, you will have done that, which is like Cash's, that's the thing gives him puppies. Okay? If you ream out someone's patellofemoral joint, this is from a medical legal case, so I had to call this negligent, so there will be a payout as a consequence. So if you've got a jig, and the PFJ is at risk if you don't use it, you have to protect that PFJ. Okay? That is the main downside of suprapatellar, and you would not get that from infrapatellar. Okay, last one. Can't undo the jig at the end. I love the way you said that, Rory. Absolutely right. So flex the knee a little to offload the jig. Also, sometimes pull the jig up, but yeah, flex the knee a little bit, and then that just takes the heat off the jig. It's because the jig is being forced with respect to the nail to be jammed like this, where it goes to the nail, and you just need to release it off a little bit. Great. That's tricky tibial nailing. Taking on a plateau. So I want you to imagine we've got a young guy. He's not particularly compliant, and he's running from the police, and he sustains. What do we got here? There's no catch. Just shout it out.
Lateral split depression.
It's a tibial plateau fracture, isn't it? It's like a sort of split depression. Okay, I'll give you a CT because that's what you want. There's the split depression. There is a little fracture line going around the back, but basically there's the depression and here's the split coming through here, and I can show you the depressed fragment on the CT. Alright, so this goes up at the trauma meeting. It's not your trauma list, you think nothing of it. You think, yeah, I'd like to do that one, that'd be a nice one, but it's not my trauma list, oh bollocks, okay, well not to worry. I'll go and do the NOVs tomorrow. It comes back post-operatively like this, and some of the trauma says, oh, is that reduced, is that not reduced? Oh, people accepting that as the post-operative view. There's no right or wrong answer here.
Not restored the articular set. No.
Okay, so would you be wanting to, what would you do next? CT, I think, yeah, okay. Oh, and that's certainly what we did. So in the trauma meeting, we decided that maybe that it hadn't been fully punched up, so let's get a CT and have a look, and we did, and it came out of that. Now, it is your trauma list, but the boss is away, and this is kind of going on table, and we need to know some tips and tricks around how you're going to get this back up again. Obviously, you're going to be taking the... So you're going to revise this, and you're going to make it all good. And I can take you back to the depressed fragment. So pretend like this is an entirely... oopsie, sorry. Pretend that this is an entirely virgin situation. There you go. There's your fragment there, down there. And... remember, he's a bit IVDU-y, so he's probably a bit more osteoporotic than you think. It's a bit of an old person's fracture in a young person.
So everything I'm saying is just what you said to me before, but in terms of, I would want to get the depression out and to reduce the width of the tibial plateau. Okay,
get the width back. Love it. Get the width back. So these are principles of tibial plateau fracture. What do you mean by width?
So
you mean that versus that, yeah? So this guy needs to be lined up with this guy at the end of the operation. Yep, good.
So,
any other techniques you can use?
So,
how did you get this bastard up? With that little island with he's got, there's his cartilage there, and he's got this kind of iceberg of bone underneath him.
So he looks good for possibly coming at him from the medial side. I mean, I think
yeah, okay. Right, punch him up, yeah?
Primarily go for the fracture site and try and, like you said before, kind of get metaphyseal bone distal to that fragment and push him up underneath.
Okay, so that's making a cortical window down here, yeah? So on the anteromedial surface, like making a tiny little incision, punching through either a DHS reamer or I tend to make a three-sided box and just punch it through. But you can do whatever you like, making a hole in his femur and then putting a punch up. Yep, and you basically go knock, 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 and you hit him and you try and bring him up. Yeah? Any other ways you can get that reduced? Because I'm thinking we're in a revision situation now, and this may not go.
Some bone graft.
Does bone graft push stuff up?
Did you go through the split and find it out?
Okay, so this is really important. But what's the role of bone graft here? What is the role of bone graft in tibial plateau fracture? Now, some people are not fans of bone graft, and some people are fans of bone graft. So let's not get into that, because no one's proven that one way or the other. But let's say we fancy doing a bit of bone grafting here. They did first time round, didn't they? There was a load of... don't do that. They did first time. Look where they put it. They stuffed it all down here. So bone graft definitely went in. What's the role of bone graft?
To fill the void.
Process. Also, you can help elevate.
Fill the void.
Okay. Bone graft does not elevate jack. Bone graft does not elevate anything. Bone graft does not do doesn't help with your reductions. Bone graft is about
filling.
It's about filling the defect at the end. Yeah? You don't put bone graft in and then hope that that's magically going to do it, because I think that's what happened first time round. You put bone graft in once you're done because you perceive there's a massive freaking hole there, and that totally reasonable. I use bone graft myself, and that's totally fine. The other good thing about bone graft is you can put some Cerament in or something that's actually preloaded with antibiotics, which is pretty appealing in this situation because we're in a revision situation, high infection rate and all the rest of it. The thing we didn't discuss was that whole thing of like counselling the patient, this may well get infected, this may be a disaster, and like going through that consenting process is quite tricky here, isn't it? Because actually, he might do okay if you left it like that. Probably not, but he might do okay. And you're basically subjecting to a treatment which might make him worse. So this is, if that was my knee, I'd probably want it revised, but I would accept that there is you're up to a sort of 10, 15, even 20% infection rate. Okay, so take fragments up with bone. This is the technique I wanted to show you. Just ignore that one on the right for a second. Here is your fragment. There's the depressed fragment somewhere in here. And what I've done is I've put this as an osteotome side on. So the osteotome goes in underneath, not a little bit underneath, right underneath, miles underneath, yeah? Miles underneath here. And then you tuck him in further than you think, and then you push the whole thing up. So you're not going for the fragment as such, you're going for the bone underneath the fragment and taking that up. And that's like, it's like, you know when you sit in a swimming pool and they turn the bubbles on, and it goes right up your skirt. It's that kind of thing. It's like you're buoying the fragment up on this cancellous bone that was sitting down in the metaphysis, completely fine, and you jack it up it goes, and that brings the fragment up without you actually detaching it and like treating it, like pick it up, put it where it wants to go. You're pushing it up with other stuff. That's incredibly effective use of an osteotome there. So if you're going to do an open reduction where you open the book and pull it up, don't go after the fragment. Say, oh, there's the fragment, I can see it there. Don't touch the fragment. Go for the bone underneath the fragment and bring that up. Much, much more effective. And then once you've got it up, the fragment doesn't want to like wobble around and fall out and like drop on the floor because it's got all this stuff underneath it to go up with it. And what you end up with is a massive hole underneath. Huge hole where your osteotome went in and goes up. That's where the bone graft goes. Use of through and through wires. Most of you will see this, but if you haven't, it's a cool technique. So basically, you see that massive wedge there, where the osteotome's gone in, and there's this kind of now level there where the osteotome's brought up all that lovely cancellous bone. And here's your fragment now up. And what I've done is I've found the fragment and I've skewered him with a K-wire. But the trouble about putting K-wires in the side is you can't now get your plate in nicely because the K-wires are in the way. So you put your K-wires all the way in and out the other side, so they're just parked up there nicely. They're still holding the fragment, but they're not in the way of your plate. Get the plate in early. So there's a tendency to do all your reduction and then put the plate on afterwards. But then by then you've got K-wires everywhere and it's quite difficult. The sooner you get your plate in, the better. And you'll notice that I've got a clamp on this one, and that means it must have been secured distally. Yeah, so you put your plate in early, and my advice is you secure it distally early. Anyone who's done plateaus with me, you'll see me do that. I get the plate and I get the height absolutely where I want it, and then I put the bottom cortical screw in. So now the plate is where it is. Now you can put like wires and stuff through the plate, and that will help you. I loved who said tibial width. That was absolutely spot on. You want to make sure at the end of your operation that this corner here lines up with this corner here, all right, or near enough. So that's one of those metrics you can use of have I done this operation well, is have I restored the tibial width. This one will be fine, so don't worry about that. It's this guy here in a Shatska 6 situation. What are these screws doing? They're just fixing that posterior extension that was going on. There he is. You see how there's that massive osteotome went in there, and that's been filled with your bone graft, right? The bone graft goes in at the end as a void filler, not as an adjunct to reduction. Yeah? Okay, how's he going to do? He didn't get infected, okay? Let's just say he did not get infected. How did he do? How's he going to do? What are you going to tell him? What's his likelihood of arthritis?
Low, much lower than people.
What are we talking? 10%? 10% arthritis. 10% likelihood of going onto a TKR at some point in his lifetime. Anyone going to advance on that?
I think it's lower than that. With
Go on.
perfect joint line restored, I think it's extremely low. I don't know the percentage, like lower than 5%. Yeah.
Okay. Is that just what Mr. Bates has told you?
No,
There it is. This has been done by multiple authors now. The failure of tibial plateau fracture fixation, 10-year survival, 97%. So when you're sitting at the meeting and the knee arthroplasty guy goes, the old boy goes, oh, don't want just a midline incision because he's going to get a TKR anyway. Just fucking just like do a sloppy job there on the plate and I'll put a TKR in him in a few years' time.
I resent that.
Okay. Try to push back on that. Push back, because basically I would put it to you that if you do a good job, even if you do a reasonable job, you are preventing them from going on to get arthritis for the rest of their life. Okay, they're not going to get a total knee because actually the lateral side of the knee is quite tolerant. If the meniscus is preserved, it's like, you know, it's obviously highly. Everyone's got a theory on why these don't go onto arthritis, but the fact is they don't. The knee is incredibly tolerant as long as you give them stability and alignment. Basically, put the tibial plateau back where it belongs. And if there's one thing you want to do is to tuck this guy, that corner, underneath this guy. That guy needs to get under that guy. So then it won't fall into valgus, right? Tuck the corner in. Okay, you can bring the joint up, but actually the joint is actually quite tolerant of that joint depression. It's more about getting the edge in, and that's the restoring the width thing. Okay? So tibial plateau, incredibly good operation, even if you do it in a mediocre fashion. But if you do it well, you've basically prevented them from getting arthritis in the future.
It's just interesting you say that, Pete, just because the lateral side of the joint of the knee is actually very intolerant. And if you lose your lateral meniscus, you're guaranteed to get arthritis within 5 to 10 years. But it's funny, I don't know why the plateaus don't go onto it to the same degree. I don't know if people aren't walking on it, doing the same stresses, sport for it.
Yeah.
But if you lose your lateral meniscus, that's the end of the knee.
Yeah. But you're a knee surgeon, right? You see people in your knee clinic all the time. But how many like tibial plateaus that have now gone onto arthritis do you see? Think about your knee jobs when you've done knee jobs. How many like removal of tibial plateau and insertion of knee replacement? How many of those have you done? I never did one during my whole training.
Does a paper by Guy, is that a big comprehensive study, the one you just had?
Pierre Guy, that's right. And there's another one more recent in the American JBJS of over 1,000 patients with a 7% total knee replacement rate. So it's between somebody 3. This is the best one, which is 3%, but theirs says 10%, 7%. But it's way less than 10. I think you might be a little bit low on batteries. Okay, that's tibial plateaus. Can I talk about removing hardware? And I would thank Alex Vriss and Nima Hadari for providing some of these images because they do a hell of a lot more of this than I do. But I think this is something you guys do not get taught at all, and this is kind of... but you do get sent. That's your list. It's an all-day list of you in the main hospital, but on your own with the SHO. And the boss has said, I'm going on holiday, I've left you some nice sweet removals of hardware. and you pull them up, and those are your 3 cases. You're like, fuck. Okay, initial instincts, just look at the cases. I'm going to tell you that nail's broken. It's actually bent, but let's, for the sake of this argument, let's say that's a broken nail, and he's broken about here. So, don't go into the why are we removing the hardware, we're just removing the hardware. What are we doing? Mo, talk about the left-hand one. Thoughts on that?
The broken nail.
Broken nail, what's the challenge there?
So the challenge would be to retrieve the distal fragment, or the distal part of the nail.
Yep. Get the bottom of the nail out. Yeah.
So we'd probably get the screws out okay.
Yep.
Broken screws, a little bit of help. And we probably would be able to retrieve the proximal part of the broken nail.
Yep.
But then it gets difficult. One way I probably would do it is to advance a hook, and then you can slide another little metal wire down to engage the hook distally and then backslap it. That would be one way of...
Yeah, there's a special hook, isn't that? Yeah, that's right. Cameron, next one across, the middle one. Tibial nail came out easy, no problem. Now it's the next one. What are your thoughts there? Easy one to remove?
Probably not.
No, I'm not. No, I'm not saying that's hard. I would look at that and go, oh great, that's a piece of piss. But is it? What's the catch? What's that? There's no radiological thing that you're missing. What is the thing about removing proximal femoral nails or proximal femoral stuff?
Trying to get the jig
You need to have the right kit. Okay, that is absolutely, you've got to have the right kit. Okay, next one across. What do you think? What do you think? What's the challenge there?
There's a lot of screws.
A lot of
hardware.
broken
broken screws. screws, yeah? Look at those. 1, 2, 3, 4, maybe this guy as well, and God knows what's going up here. A ton of broken screws, right? So, easy to get out, not easy to get out?
Not easy.
Well, sometimes they are. Sometimes they just like fall out and they're like a piece of business. Oh, sometimes they're an absolute bitch. And it's impossible to know whether this was going to be a bitch or whether it's not going to be a bitch. And sometimes you think, oh, this plate's going to be a nightmare. And actually it's this plate that's the nightmare. And vice versa. So it's hard to know, isn't it? This one was all about getting the right kit. What's this one all about?
Getting X-rays.
Yeah, you will need X-ray, yeah, for sure. What's this one about? Having the right kit, exactly, yeah. Having the right kit, having the right kit. Okay, let's do it. So this one's about extracting the nail, we'll talk a little bit about that. This one's about removing screws, and then Mo discussed removing the nail tip. So we're just going to tuck into those each time. Extracting the nail, that's basically taking a message camera, and you've got it, absolutely. Every proximal femoral system has a system for taking it out. If you've got that extractor, it falls out like it's like, that was such an easy operation. If you do not have that kit, the correct thing which fits into the thing and locks into it and clicks in and all the rest of it, it will an absolute pain in your ass. And you'll be like messing around with pliers and all sorts. So get the right kit. And also get the right extraction kit. Everyone's got a different one. So Striker do a Timex system. Depew, this is one we've got. It's called the Opere system. And there's a universal one which does spines as well, called the Schuckler system. And they basically come with a bunch of tools which are good for removing screws, and we'll talk about those in a minute. Getting the entry point of the nail, getting down to it. So if I use the example of a tibial nail here, when I was training, I was taught just to like make a cut and like just start digging around in the proximal tibia until you find the nail. And I would strongly advise you don't do that. It's very easy just to make your incision and get a guide wire and put it down into the nail. If you've got a cannulated awl, you can then put the awl down the wire and just start just to clear out the top of the nail. And then you can take both of those out and then put a conical bolt straight down. And you haven't actually exposed the nail at all. You've just you've done it all relatively percutaneously. So, but even if you don't, even if it has got overgrown bone and it's been in there hundreds of years, use the wire to locate the end of the nail, so when you go for it, you go straight onto it. Yeah? Guide wire down first, then you can do a cannulated awl or an awl. If they've got an end cap in, that takes you to the end cap, and then you can put your screwdriver straight down, and then you can go for your conical extractor, which just links into the nail, locks, and now you can slap it out. All right? It works for a tibial nail, and it works for a femoral nail as well, particularly, even more so with a femoral nail.
Can you take out a tibial nail suprapatellar, or would you go infrapatellar to take it out?
You have the choice. You have the choice. But if you're going to go suprapatellar, you've got all of those considerations that you've got to have the jig right down. You've got to make sure you've got done a bit of a medial release, and you've got to make sure that your tube does not migrate out with all the dicking around. So actually, it's probably easier just to take it out infrapatellar, because you're not. These are sometimes challenging cases, and you don't want to. Just a moment's loss of concentration and you've damaged the PFJ. So I think most people tend to go infrapatellar. Also, you're often taking these out for infection or a suspected infection, and therefore you're kind of always having that in the back of your mind if you're dragging it back through someone's knee joint.
There's no rule that you have to go the same approach.
There's no rule. There's no rule, because it's a new technology, isn't it? Same goes for femoral. If you are taking hardware of any description out of a femur, maybe not a medial plate, but anything that's lateral or a nail, my advice to you is to go lateral, put the patient lateral. We're not familiar particularly, you guys aren't particularly familiar with putting patients lateral. That's not, I'm not sure about that, I've never done it before. But actually, that's a bit of a recurring theme in this talk, is that putting patients lateral is so much easier to take a nail out with them in the lateral position. Much easier to take a plate out with them in the lateral position. It's just sitting there in front of you, and you just like do. Because often these are quite, as I say, challenging cases, getting screws out and stuff. And then when you're all operating like this, it's so much harder than operating like this. So lateral position. Removing screws, how do we get those out? Well, you've got the screws go through the nail, these guys here, so you can If they're loose, you can actually knock them out from the other side. Sometimes you start turning a screw and it just doesn't move, right? And in that scenario, you go around the other side and knock it through because it's loose. Alternatively, if it's broken, you can take one side out with your screwdriver and then you can knock it through there. Yeah, so that clears out the bottom end of that nail. For getting screws out in general, these are the sort of basic tools. Just guys, name those. What have we got here? What's this guy? Crown reamer. Yeah. And what does he do? He over drills, doesn't he? He goes over the top of a screw. Yep, absolutely. What about this guy?
Conical screw.
Conical screw. So where does that go?
It digs it creates a new thread into the head of the screw.
Into the head of the screw. And so that when do you use that?
When you strip the head.
When you strip the screw head, exactly. When you strip the hex or the star, exactly. And this guy here, what's this? Obvious, but just when would you use a drill? When would you use that guy?
Cold welded the locking screws in.
Right, so you cold weld, you just cut, and then suddenly the hex goes. Yeah, it's basically cold welded in. What implants classically cold weld? Sorry?
Locking plate screw.
Yeah, locking plate screws. Yeah. Which ones? Sorry? Titanium ones, yeah. And classically, the older titanium ones, the list plate was the one that classically did it. More modern ones theoretically don't do it quite as much, but they still do it a bit. But yeah, the older titanium locking plates are the ones. Stainless steel doesn't tend to cold weld. Okay, so I've just gone through these. Sorry, it's a bit of a mess this, but can we start at the top end? So you can augment your screwdriver as well. Yeah, you can actually, if you're turning a screwdriver, keeps going, you can put a little steri strip or something over, or a bit of foil over the end of your screwdriver and put that in. That can be just enough interference to allow it to get it to turn. If the screw's super tight, you've got a good bite on it, but you're just super tight, you can try tightening it first and then untightening it. Not if it's going through a plate, but if it's going just in a very, very hard bit of bone, you can forwards and then backwards, and that's sometimes enough to get it moving, and then you can take it out. Exactly as you said, this is the reverse thread conical screw. So he goes in, he turns in the opposite direction, so he's trying to undo the screw. He burrows his way in. Don't do it on power. Yeah, don't do that because it's got too much momentum and it just cuts out all the metal. It's something to do on hand, and then you go like that. Yeah. If they're cold welded, exactly as you say, Joe, if you drill the shit out, you're basically destroying the head there. And what that ends up doing is it ends up cutting it down. It does leave you with this though. It leaves you with a stalk that you basically chopped off at the level of the bone. So that has to be dealt with. You can dig them out. And this one has been dug out. This is one of Alex's nice pictures, but you can see this one's been in since 1950 something, these guys, these really old, super old screws often have crazy like attachments at the top, like old Phillips heads or just weird things. Well, we haven't got a screwdriver that fits that. So actually, in that scenario, you're almost treating it like it's a tumour, and you're just trying to just chop the fucker out without doing too much damage to the surrounding tissues. And then finally, you've got this guy over-reaming the broken off shank. So here's this guy here, right? You've chopped off you've killed off the head of the screw. You're now left with this guy. There he is. And there's the more modern one it's basically a crown ream that goes over the top. And then inside, it's got these internal threads that kind of locks it. It's on reverse, and it goes down. It locks over the head, and then spins it out. And that you can use it on power as long as you're going slowly. But the important thing with this is to take it out regularly and clear it out, because it tends to get blocked up with swarf. All right, so it's over-reaming a broken off shank. Removing the nail tip. How are you going to do that? Well, the place to start. So this is supposed to build, but I just didn't have quite enough time. It's supposed to over-ream. So stick with number one. Over-ream proximally. It gives you a bit more space. You don't have to do this, but it gives you a bit more space. So you've knocked the proximal part of your nail out, and now you're going for the distal bit that Mo was talking about. If you ream down to it, it just gives it a little bit more space to move around and find its way out. Nails are often pretty tight, and this guy is super strong, so you can just like fucking whack it, right? And it comes out. But when you're down for this distal bit, the grab is a little bit more tenuous, and so you don't want to be putting huge amounts of force through it. So reaming down to it is beneficial. Use a hook or a grabber. That's your first go-to. You can either go and grab it with a piece of grab. It's probably a bit old school nowadays, but that sort of thing does exist. And if your fragment is slightly jammed one way or the other, you can use that to kind of like realign it and make it straight again. But most of the systems now have something like this, which is a hook with a back slapper on it. And that would be my immediate go-to. In just like you put the hook down, it goes right the way through the end of the nail, boink, and then you just hook it, and then out it comes. The other technique, if you don't have a hook, is the multiple guide wire technique, which is this. So you put down a ball tip guide wire. Yeah, so there's no nail in here. This is an exchange tube. I probably wouldn't bother with that, but put a ball tip guide wire. You could put a gentle bend on the end just to help find it into the nail if it gets stuck. So down he goes. He comes out the other end of the nail. You then put a non-ball tipped guide wire down adjacent to him, and he pokes out the end as well. And now you back slap on the ball tip, and it jams against the other one like that. And then you can knock it out. You put a T-handle chuck on that. And there you go, there's the technique there. You can see so they're putting down two guide wires there. You see a ball tip and a non-ball tip, and then out he goes. Alright, so that's taking out your distal fragment. Nice. Any questions on that? Alex, any? Oh, sweet.
No, just always concentration for failure.
What's the most important thing when you're taking out hardware? The thing that everyone always forgets.
Isogenic fracture.
Sorry?
Isogenic fracture.
It doesn't usually cause no. You can do, yeah. Something you need to remember in every single case where you're taking out hardware.
Fractures united.
Yeah, you could do a little EUA afterwards, make sure it's united. Yeah, but you've usually confirmed that before you go.
Check we have the correct number of metal.
Well, you've got your X-ray, like it's all coming out. Yeah, sure. Yeah.
Retain metal.
Yeah, the same thing. Yeah, yeah. It's the thing that we always forget, and then you think about, oh bollocks, you think about it afterwards. Always send samples. Yeah, because the query around these things is usually, is it infected? Is there some deep infection? And if there is, now is the perfect time to get microbiology. You're never going to get this opportunity again, because if it does get infected subsequently, someone will start them on antibiotics, and that will be the end of that. Okay, so you've got a golden opportunity not to give antibiotics at induction, but take some samples first, then give the antibiotics, and then take out all the hardware. All right. So whenever you're taking out hardware, whenever you're doing non-union surgery, removing hardware, take some samples.
Do you send the screw, for example, do you send the screw tip, or would you be...
You can send bits of metalwork. I think that the preference is to send the membrane around the plate, that kind of membranous stuff that sits adjacent to the plate, that kind of like slimy stuff that you scratch off with your periosteal as you're coming down to. That's the really good stuff. Alex?
One tip. When you remove a nail, just before you engage the nail, just leave one locking screw in the nail. No, so it doesn't start spinning. If it's a straight nail, you cannot engage.
Yeah.
And when you engage the nail with a conical device, then you remove the locking screw and pull it out.
Great.
It helps a lot.
Just to answer Mo's question in terms of sending metalwork, some microbiology labs, and actually they're increasing the number, have a ultrasonic hater. So if you've got a micro biofilm, they ultrasound it, or they agitate it, they get biofilm and grow. So it's not always, we don't have it here, but some labs do.
Cash, I've got 4 minutes to do periprosthetics.
Take 11.
Okay. Here's your fracture. Someone who hasn't spoken yet. Oh, one of you guys at the back?
It's a periprosthetic of a hip replacement.
Yep.
And Q would be. It looks like it's just nothing.
What's a B?
Well, it's C actually. Sorry. It's got the it's below the implant. So it's involvement.
So what's A?
A is around the greater trochanter.
B is?
B is involving the stem, and C is below the stem.
Okay. Is this involving the stem?
It is involving the stem, so I guess it's B.
Okay, so I'm buying it, yeah. Hold your nerve, man. You were doing fine. So it's a B. And the B's are subdivided into?
1, 2, and 3.
Okay, what's a B1?
So it's about loosening where the implants.
Right, whether the implant's good or not. So B1 is a stable stem. B2 is a, shout it out, unstable stem. B3 is a unstable stem which is like wobbling around with loads of bone loss. Yeah. Okay, great. So you're calling that a
B1.
Okay, B1. And there's obviously a total knee replacement down. So, ignoring the operation for a second, tell me about pre-op workup. How are we going to decide how to treat this?
Imaging.
Okay, imaging.
CT scan just assess the extent of that spiral.
Okay, that'll tell you, yeah, because it might spiral right up here, mightn't it? So I'm buying the CT. What else will the CT tell you?
I'll tell you about the distal fragment.
Sorry?
If there's any other fracture in the distal fragment, they're extending down as well.
Yeah, okay, yeah, fair enough. What else will CT tell you? Right, it might help you define a B1 versus a B2, mightn't it? Because let's say there's a bit of a sclerotic line around your tin hip. It might around the femoral stem. It might be, that might push you more towards revision. Yeah? Okay. What else might push you more towards revision?
Age.
Function.
So whether they're ambulatory or
Yeah, okay, no, ambulatory, yeah, okay. Okay, age, all right, fair enough. If they're super, super old and completely non-functional and they've got a fracture and a loose hip, then you might decide to fix it. But let's just say this is an ambulator.
Acetabular component.
Okay, that's fine. But that's a good point. Yes, absolutely. Your CT would include that as well, wouldn't it? Agreed. What about history? Yeah, okay, inflammatory marks is infected. That's a great point. That's a great point. Yeah. What else?
side pain or pain on right.
Nice. Okay, so prodromal pain. Yeah. Was this a high-functioning hip replacement or not? Because if it was, then that leads you even more to thinking this is B1 and therefore internal fixation versus B2. I'm going to replace it. How important is it to get that right? Is it really? I mean, like, because I don't really do tin hips, so I'd like to fix the whole fucking lot. So, does it really matter if you fix a B2 or if you do an arthroplasty in a B1?
It matters more if you fix a B2.
What does it really matter?
Because if you fix a B2, you still want to use component.
Right. Okay.
But
And
if it requires a B1, you can get away with it.
Yeah, that's it. Well, yeah, but it's a much bigger operation because you have to then bivalve the femur and get the stem out. So getting it right is well recorded as if you fix B1s, if you fix B2s, they have a much higher revision rate. If you do arthroplasty for B1s, they have high intraoperative complications. So getting it right is actually important. Okay, so defining B1 versus B2 is important. There's nothing you can do which people talk about, which is intraoperatively you open this up and you give the stem a whack and you wiggle it around and you see if the stem moves inside. I've never actually seen anyone demonstrate a loose hip by doing that. But, some people swear by it, so I'm not going to say no. But I think, generally speaking, you've decided before the operation whether this is getting a stem or arthroplasty. Okay, positioning. How are you going to position them?
Lateral.
Always lateral? It was a trick question. Yes, always fucking lateral. Yeah, absolutely. Yeah. It's so much easier in lateral position because the femur's just lying there for you. And I know we're not familiar with doing that. We do a lot of our femoral work supine on traction. Doing the supine on traction is not the way to go. Absolutely. Because you're going to be putting cables on there and having it all in front of you is considerably easier. Okay. And what's your construct going to look like?
Something designed for the purpose, like an NCB plate.
Sorry?
Something designed for the purpose, like an NCB plate.
Okay, fine. Yes, so purpose plate. How many holes? How many screws?
So you want these three that is long as probably 4 screws distal to and then proximal to the fracture out of the zone.
Okay, so I tempted you into that. Just describe where it's going to and from.
So you'll have a lateral locking plate.
Yeah.
So you could try and be minimally invasive and slide the plate.
From where?
So I guess there might be a stress riser at the site of the total knee.
Sorry?
Are you saying that there might be a stress riser at the site of the total knee?
I'm asking you. What's?
Yeah, so I would want a long plate with 4 available screw holes additional to the lowest point of the spiral of the fracture. And then in terms
So 4 holes below, 4, okay, so then 3 more, so about there. Yeah?
Yeah.
All the way down.
All the way down, all the way up. Okay? What we don't want is this coming back fractured again. Okay? So the solution on one of the take-home messages, if you're fixing a periprosthetic, you do not want to be back in this femur again. So don't allow it to fracture again. Don't give it the option. You fix the whole freaking thing. And you go and you overlap the hip replacement considerably. And this is an important point. If there's one take-home for periprosthetics, and in fact for geriatric fractures in general, it is your post-op instruction, excepting there will be a few changes to this, but the vast majority, your post-op instruction should be weight bearers tolerated. Yeah, it is after a DHS, it is after a hemi, it is after a tibial nail, it is after a femoral nail, and it should be after a periprosthetic fracture. And with that in mind, of course, the first thing it needs to say is sometimes things need a THR. So if you're fixing B2s, you'll have a lot of bad results. So you've got to define that, and this was a poorly functioning hip. You can see that see how the mantle's separated off the stem down there. This is loose. There's no point in fixing this guy. This needs a long stem revision, and I hate myself for saying it, but arthroplasty is the solution for that situation, not internal fixation. All right, and it's about half and half for periprosthetics, about half and half in terms of B1s and B2s. If it's placing go lateral, I'm loving you all said that. That's great. Lockers in the metaphysis, non-lockers in the diaphysis. Okay, people love putting lockers all the way up. So, yeah, lock, lock, lock. But locking screws up here don't really add anything. They don't add anything in the diaphysis. When was the last time you saw a DHS plate pull off? They don't. The diaphysis is fucking iron, even in old people. So you get really good bite in the mid-shaft of femur with non-locking screws. They're a slightly smaller diameter. They're much less likely to cause a periprosthetic fracture coming out through the top. So non-locking screws in the diaphysis, locking screws in the metaphysis. That's what they're for, yeah.
If the plate is sitting off like that one, would you still do a non-lock?
If it's sitting off on here.
The other X-ray, where the arrow is.
This guy?
Yeah, the blade is sitting off a little bit, but that's the optimal position. Would you still put a non-lock?
Yeah, I would say as you put your non-locking screws down 1 and 2, it'll slowly bring the plate in.
Okay.
And if it's sitting off a little bit, I don't think anything is lost. The main the frictional force with the head inside the socket is in a fully tightened screw is massive. Go long, protect the rest of the bone, long overlap with the stem. So this is the one we just saw. This is what we ended up doing. As you say, we've basically reduced the fracture with a couple of thingy bobs, and then we've a massive spanning plate right from down to Beersheba. Yeah, right from the bottom, right the way up to the top. They're two different cases. If I was critical of myself, I would say that this non-locking screw down here could have been a bit lower. The plate could have been 1 hole longer, couldn't it? And that way I'd have got a screw right down there, and then that's put that one to bed. So, huge spanning fixation. What is the mode of healing of most periprosthetic fractures, the B1s that you fix? What's the mode of healing? Absolute or relative? Relative, yeah? This is not absolute stability. You're not lagging fractures back together. You're not trying to squeeze it and all of that. This is relative stability. Cables are relative stability. They feel really tight when they're going on, but actually you can move those cables around on the bone, even fully tightened. You can wiggle the bone around. They are approximators, if you like. And so a long spanning segment with no holes in it whatsoever. I love what you said back there, but lots of screw holes, empty, allows it some bend, because the fastest way to heal any fracture is through relative stability and callus formations, not through direct osteoidal healing. You want callus. Callus is good. So you want bend, and you want this patient weight bearing.
What do you make of, a lot of people will say that cables are no-no, they cause infections and they ship cross. What would your response be to that?
Oh yeah, so that's a little bit delusional as well, because people think of cables, you think of a cable around your own neck, don't you? We have this idea of people talk about you strangling the bone. It's total bollocks, isn't it? Absolute bollocks. Because we know that the bone gets its blood supply from the periosteum. Periosteum doesn't go up and go up in one direction from here to here, and if you don't hear, you're denuding all of that. That's not how the periosteum works. It gets blood supply from muscle attachments along this way. So if you put a cable round and squeeze it, that's absolutely fine, as long as you haven't stripped the periosteum up and down for 10 centimetres top and bottom. But a cable right there does not strangle the bone, and people who use that term are talking shit. Okay, distal femur. So here we go. A bit of a non-union situation. Distal femur goes in, which is a sensible thing. But if you've got a tip meeting a tip, again, don't. I know that it's been a long operation and all of that, but don't let this bone. Don't give it the option of breaking again. Yeah. Don't give osteoporotic bone a chance of refracturing. So we've just stuck a little plate across that stress riser. That ain't gonna trouble us again. Longer constructs prevent reoperation. So here you go. This was obviously a B1, wasn't it? It's a nice B1. Oh, we'll fix it. There you go. We've got four. There you go. You were talking about 4 cortices. Look how many screw holes they left empty. Like, well, I suppose they've done an all cable construct here. That might work. That might work. But sometimes that policy doesn't work, yeah? So you have a break, you put a plate, it heals, it bloody healed, it was fine, and then it broke above it. It was so unnecessary, that, wasn't it? Totally unnecessary. And I will put it to you, the boss is going to hate you for it, but when you're in this situation, this plate goes not to here, it goes to here. Right up to the top. And they're, oh, do you have to use such a long plate? I didn't want the bone to fracture again, boss. Or you could just do what they did in the end, we just put a nail up. So a retrograde nail for a B2 down here, with this much bone, actually a nail would have been a better option in hindsight, provided this doesn't have a box, and I haven't got a lateral there, but assuming it didn't have a box. But consider retrograde nail. Avoid cable-only constructs. Cables are not great for stabilising these things on their own. You've got to have some screws up top, or they're just not very strong. You definitely can't weight bearers tolerated on just cables. Almost done. Lateral plates sometimes not enough, so you can either do a nail and a plate. Basically, you want patients to weight bearers tolerated. Yeah, you want the weight bearers tolerated. In order to do that, if you just put a locking plate up, you will always worry that they're going to bend the plate. But if you put a nail up as well, or if you've double plated, then actually that makes it a whole lot more stable. And now you're thinking, I will be happy to weight bearers tolerate this patient. Massive difference, not a big deal. So you fix someone's distal femur, all you have to do is take an ipsilateral proximal tibial plate, turn it upside down, so it comes from here, turn it upside down, it fits perfectly to the medial side. Yeah? You can put that in MEPO as well. Femoral arteries are right up here, so it doesn't have to go right up and threaten that. They go behind the femur anyway. So it's a low risk, very easy adjunct to your lateral plate, and then you can walk fearlessly, right? With your goal of treatment being weight bear as tolerated. I've run out of time.
Run out of time. Always leaving one thing more.
You're never going to hear about what happened to, how you deal with that fat patient. Another day.
There is no answer. It's like the end of Lost. Cool. Thank you very much.